This is PopHealth Week on Healthcare Now Radio. I'm Gregg Masters, Managing Director of Health Innovation Media and the producer co-host of the show. Joining me in the virtual studio is co-founder and principal co-host at PopHealth Week, Fred Goldstein, President of Accountable Health, LLC. PopHealth Week engages industry leadership and stakeholder voices spanning payer, provider, patient, vendor, and regulatory communities in population health best practices and strategy. Connect with us via www.popupstudio.productions or follow and direct message me on Twitter via @GreggMastersMPH, and that's Gregg with 2 G's. On today's episode, our guest is Carolyn Yang, MD, attending physician, home hospital program at Brigham and Women's Hospital. Dr. Yang is interested in the intersection between healthcare policy, business, and innovation. Her academic background is in neuroscience and entrepreneurship and management via Johns Hopkins University, with extensive leadership and research experience. Her goal is to ultimately improve patient outcomes and care delivery, reducing costs, and innovate better solutions. And with that brief introduction, Fred, over to you.
Thanks so much, Gregg. And Dr. Yang, welcome to PopHealth Week.
Thanks. Happy to be here.
Yeah, it's a pleasure to finally get you on the show here. We met at HIMSS. It was an interesting thing as you were doing some stuff around that. So tell us, as I understand it was your first time at HIMSS, what were some of your thoughts?
Yeah, well, I think it was really exciting just to see everyone from different industries and different stakeholders in the healthcare industry come together and talk about really hot topics and what's new and different challenges and brainstorming, different solutions that are creative and novel. So that was like a really great forum to see all of that, to witness all of that, and to talk to everybody who is in that space that I typically don't get to interface with on a regular basis.
Yeah, I agree. I thought it was very good this year. I really enjoyed the opportunity, one, to get together with people, obviously, and two, to look at some of the new tech and IT, et cetera. But before we get into this really cool topic on taking hospital care and moving things like that into the home, why don't you provide our audience with a little sense of your background?
Yeah, so I'm currently a practicing hospitalist physician at the Brigham. I practice part-time in the traditional hospitalist model where I see patients who are acute level of care in the hospital, but I also work part-time in the Brigham's home hospital program, which is a newer program where we do hospital level care, but in the home. And so it's two different environments doing the same type of medical care. And so it's been really exciting to see the common grounds and also the differences in the way that we deliver acute care. So that's what I do currently. My background and interest is in health tech and innovation, digital health, which has been a much more busy space these days in the industry. And so I've been excited to see the different solutions that people are coming up with to make healthcare more affordable, more accessible for all those players who are involved, including patient and provider.
So, Carolyn, what made Brigham decide to sort of go into that direction with home hospital work?
Yeah, I mean, I think initially it was an academic curiosity of, we weren't the first to come up with it. Actually, back in '94, Johns Hopkins had a similar idea and began to execute it in practice, albeit a smaller model. And, I think what the Brigham was looking for was sort of something innovative, but that was cost effective. And while, the finances of it initially may have been more challenging just given reimbursement and such, it was a much more enticing option for patients and providers alike to be able to provide care where the patient is at, more literally.
And I find it interesting. I remember when I first mentioned it to you, I said something to the effect, hospital at home. And you said, no, this is home hospital. It's an interesting play on the words. Can you sort of discuss the differences as you see them?
Yeah, I mean, I think the technical term for all the programs is referred to as hospital at home. Brigham calls it home hospital. I actually think you could argue both are pretty similar, but the idea of hospital at home is that the hospital is existing within the home. And so you kind of envision all of the resources a hospital has just like stuck in the home. But in reality, we've created our own ecosystem of hospital in the home, in the sense that the home hospital is actually somewhat different when it comes to the resources and the build of our structure of how we deliver care that's acute level at home. So it's not a mirror, which might be implied by hospital at home, but it's kind of a unique model that does the same thing, but in a different environment.
Yeah, Caroline, I think you explained it perfectly, and it really made a lot more sense to me when you did that. This is a different place. It's not a hospital dropping into the home, and I thought that that was really a good way to look at it, and probably will help as we try to develop this out further in the future. It is its own unique environment. So when you think about that, and I know there are a lot of places we can go into, there are some studies that have been done, et cetera, that we can talk about, but how do you select, first thing I would say is, how do you select patients for that?
Yeah, I think every hospital model is different in that, the diagnoses that each program is capable of caring for differs based on their staffing, differs based on what specialty support they might have to take different diagnoses, differs based on the radius in which they make decisions at home, because it changes the time that it takes to care for somebody in an acute situation. And so all of those factors will change what diagnoses are taken care of at home. But for example, for Brigham, we do it based on a variety of factors, including geography. So we do 10 miles around the hospital, and anybody outside of that wouldn't qualify. We do it based on social situations. So like if someone's homeless, we can't safely care for them at home. If they're in a group home, sometimes that's not an option. So, or rehab, there's a lot of different environments that a patient might live that is not a good fit. I like to say not a good fit because who knows in the future, depending on resource changes and other things, there may be room for diagnoses and situations that we don't care for now that we could care for in the future. But for right now, based on the medical piece, we care for a lower acuity, and that makes sense because we are not bedside all the time, but we do monitor them remotely all the time, and we have access to them all the time. So that facet is definitely a pro, but it does, make it so that more acute patients are not as safe in the home hospital model as we have it right now.
Mm-hmm. And you talked about this remote patient monitoring. Did you build that system? Are you running it on top of somebody else's platform? What did you use for the remote patient monitoring?
Yeah, I think it started out more as a hodgepodge. So we kind of found third-party applications, and we did not home grow any remote monitoring or platforms. So the device, the hardware, and the software is third party, and we contract with them to some degree to, make our ecosystem of remote monitoring. So, so we use different vendors, and I think that's always in flux, and depends on all this new stuff that comes out day by day. We are always reevaluating kind of what tech is the best for our model.
Mm-hmm. And I assume you've integrated that into your electronic health record system, et cetera?
That is a goal. There's a lot of different software solutions that do offer that. And so, like I said, we're constantly looking for, bigger and better solutions as we grow ourselves. And so while something may have worked and been feasible when we had a smaller census or a smaller team, or less complex patients, as we grow, I think we are constantly needing to look at what solutions we're using. But ideally, we do integrate, what data comes from those remote monitoring devices and onto the platform that we use, and having the data from that platform integrate with the EMR, even if it's just unidirectional, so that all of the data is in one place. Because I think the biggest challenge with all this tech is that there's just so much data, and it's hard to really track down where one piece of data came from, to vet its integrity, to make sure that it's securely being transmitted and accurately being transmitted. And so there is still redundancy. I think right now, as we transition to different solutions, the redundancy is sort of a fail-safe, but at the same time, it does create opportunity for more error. So it's all things to consider, but I think, ultimately less solutions, more integration, more interoperability is really where we need to head.
And I notice you have this team of folks on the website that are in this home hospital program, physicians, I think it was like a nurse practitioner or someone at that level. And then you also had EMTs, which I thought was interesting. Is that because these people are at a house and you might have to run out and do something, or?
Yeah, exactly. And again, like we've changed and grown so much in the past year, as many programs has, to keep up with the demand in the full hospitals. And so a lot of our model has changed over the past year. So to give a little history, initially we weren't using EMTs at all. It was me and a nurse. That was pretty much it. And at nighttime, we would have access to EMTs for exactly what you were explaining, in that if we had an emergency call, the nurses weren't on during the night, and we needed extra support or hands-on. We did contract with a third-party paramedic team that would go out and sort of see the patient in an acute situation. Then fast forward to our current model, we basically integrate EMTs as an equivalent to our nursing staff. So we see patients on our rounding during the day with both EMTs and nurses. So they're equivalent in that regard. And then we still have the nighttime paramedics that go out for emergencies. And now, Brigham has an internal team at Spalding. So now we have Spalding folks who are also taking that role. And it's been challenging, as you know, in the healthcare system the past year and probably beyond. Staffing shortages has been a big problem. And so we are not, unique in that we don't have that problem. We very much had to be, to improvise and to be creative about how we fulfilled the staffing needs of our team to care for the patients in the census that we had, which was growing. And so that's how we've gotten sort of creative in using the paramedics, our nursing team. Obviously, our MD team has grown as well. So yes, that's our model. We don't have NPs or APPs right now. The MGH team, actually, they have a home hospital team. It runs very differently, but they do utilize APPs. So like I said, every home hospital model is different in the way that they're structured.
Have you been able to compare between models and see any differences in outcomes, costs, or things like that?
So I've looked at a lot of data from different groups like Johns Hopkins, and they've done a lot of meta-analyses and stuff like that across different programs. Again, the data was pretty sparse before 2020 because, as we started the pandemic, and I started before the pandemic, there were a handful of programs that were running at it, at a census that was sort of sustainable. And then as the waiver from CMS came out to reimburse inpatient care the same as home hospital inpatient care, then you saw this huge growth of different home hospital programs. So now we're over 200. Just in like 18 months, we went from, under 10 to over 200 hospitals or programs in the model of home hospitals that are taking this waiver. So it's, like I said, in healthcare, generally change happens pretty slow. But in this case, we definitely had both the financial and like philosophical motivation to take advantage of these types of innovative programs. So it's been exciting to see them grow. And I imagine in the next couple of years, we'll see even more research and data looking at outcomes and cost reduction than we have. But to go back a little bit, like Brigham did 2 RCTs and were the first in the home hospital space. And the more recent one back in 2020, really showed that there was a cost reduction, that the adjusted mean cost of the acute care episode was 38% lower for home patients or home hospital patients than control patients who were in the hospital. And that's looking just at direct costs. So meaning the physician, non-physician labor, supplies, medications, testing, but that's not even looking at the opportunity cost of opening up beds for more patients that are sicker that may bill higher and those types of cost savings. So I think there's a lot of data already that is very supportive of cost reduction opportunities and such for home hospital. But I imagine in the coming years with all these new programs, there's going to be way more.
And if you're just tuning in, you're listening to Pop Health Week on Healthcare Now Radio. Our guest is Carolyn Yang, MD, attending physician home hospital program at the Brigham and Women's Hospital in Boston, Massachusetts.
So, and you had mentioned that these, it was allowed to open up these services at the same rate as inpatient. So, obviously, with a 38% relative cost, I would assume at some point we can see these costs come down by using services like that.
Yeah, I imagine. And I think, a real big factor in that is reimbursement. And we have gotten lucky with the CMS waiver, but again, that is technically only going to last till the end of the public health emergency, which has been pushed, as we know, quite a bit. And so it does look like, come July, that there may be an end to the waiver. And so there's a lot of advocacy happening around trying to extend it so that it can give us some time to really put together a good policy that will last and hopefully be permanent so that different home hospital programs can continue to be sustainable. And so I think, different home hospital programs will come up because it's financially sustainable. And I think that's going to be the biggest barrier to getting more programs. And I really hope that losing the waiver, if it ends up worst case scenario, that we don't have a lot of programs kind of dissolve. And I do think that may be an unintended consequence of that loss.
Mm-hmm. I think it makes sense to keep that moving forward and allow that option of service, particularly if it can generate, similar or better outcomes at a reduced cost. It's the way to go for sure. We've been, you talked about change is slow in healthcare, and Gregg and I have been sitting here for quite a long time with that mantra, trying to see when are we going to flip the switch on this baby. And so it's nice to see things like this. Approximately, you talked about efficiencies. Approximately how many patients do you have at any given time in home hospital?
Yeah, so in our current situation, we are seeing about 15 to 16 patients a day. And, with discharges and admitting, that's typically where we sit. So we're taking like 1 to 3 new patients a day. And then, like a typical hospital, discharging, here and there. So we're generally taking care of 15, 16. But just like I said, 18, 24 months ago, we were looking at maybe an average daily census of like 3 to 5. So it's really grown quite a bit. And I imagine, our ambitious goals for the entire MGB system, the Mass General Brigham system, is very ambitious and will really expand, the amount of patients that we care for at home. And so hopefully, like with the right tech solutions and financial support from the organization, we will be able to make that happen. And again, it won't be just with Brigham, it will be a joint effort of Brigham and Mass General and maybe Newton Wellesley and Salem Hospital. So we're really trying to get on that now to grow what we can offer in terms of home-based care.
Right. I was wondering too, this whole issue of equity. And, when you think about home hospital, obviously there are certain requirements for a home. And do you see ways, or are you beginning to look at how you might address those inequalities?
Yeah, so I think it's a multifaceted issue. I think technology dissolving inequities in healthcare has arguments on both sides. I think, obviously technology, people don't have to leave their home. If they do, this idea of telehealth and providing care where the patient is at via technology does increase access. I think that's absolutely number one. But I also think that technology requires you to have good internet access, for you to have, good connection, for you to have the best technology available to you in terms of a phone or a computer to make that equitable for all those who are on the receiving end of digital health or digital health solutions or telehealth. And so I think that on that side, there's a lot of work that needs to be done to ensure that those challenges are addressed and that the needs of those who are less fortunate to afford technology solutions, that those people are not ignored. And so I think that, yes, technology can meet people where they're at, and it can help provide care to those who maybe don't typically have the means to meet you where you're at the hospital or in the clinic as a provider, that you can meet them where they're at in their home or on the street or in the car or wherever. And it allows people who maybe work 3 jobs and, just need to hop out to the break room and take a telehealth visit. Like, I think, that is the challenge, but also the blessing and opportunity that exists within delivering care with different technology solutions. And as far as home hospital goes, I mean, we really don't discriminate. We will take anybody who comes through the doors of the emergency room or who's in the hospital, and we don't look at anything beyond those criteria that I mentioned earlier in terms of geography. And it is challenging. Like, we would love to deliver care to the homeless, but there's just no safe way to do it. So I do think there's limitations, but I think that overall, on the whole, we are serving, this issue of health equity in a positive way.
So as you look at this equity issue, obviously, you look to get technology into the home, and there are different ways to do that. But are there, I imagine, there may be certain home environments where you need to go in and just actually clean the house to provide a safe bed, a clean bed, and things like that. Do you look at things like that, or provide food service in home, et cetera, as part of the program?
Totally. So we do our best beyond the 4 walls of their home, which we do rely on the patient to provide. We do provide additional supplementary services like meal delivery. And it doesn't have to be for someone who doesn't have access to food, but we help with people who don't have access to the right food. So for patients who have heart failure, and they're being admitted for a flare or an exacerbation, and they don't have anything but canned soup at home, we will provide, delivery to their homes of the food from, contracted organizations that can provide that type of food, like community servings or other groups. We also provide home health aides to provide additional assistance in the home. And while we don't provide them for the purpose of home cleaning, sometimes, if there is a small need that will really enhance their medical care, we will do, they are able to provide, those services.
Mm-hmm. And what's been the response from the patients so far?
Oh my gosh. Every time they come back to the hospital, where's home hospital? Like, can you call them? I think a lot of them love being at home, being with their families, especially with the pandemic, both on the front of inpatients not often having the ability to have visitors or the visitor policy changing all the time. That is a big plus for them to be able to be with the ones that care for them and that they feel comfortable with. It helps them feel better being at home, eating their own food. That meets their cultural needs too. I think that's a huge thing that goes back to the health equity and cultural sensitivity, is seeing that everyone's diet is different at home than it is in the laboratory of a hospital that we have, right? We get to control when they get their medications. We control, what they eat. We control, how much activity they get. It's like a laboratory. And so no wonder we get, relatively satisfying results when we can control all those things, compared to in the home when we do leave our patients to really be autonomous and make those decisions with our support, but they're still eating their home foods. They're still, relying on their home supports to help them take their medications, and not relying on us to be there to remind them at every moment what to do.
So do you have, or have you seen much of, well, they were in-home hospital, but we got to bring them in?
Yes. So we definitely have patients that they are doing okay and appropriate for home hospital when they come to us. But as everyone knows, different conditions evolve differently, and sometimes people get worse, or something that we couldn't have predicted happens, and they do need a higher level of care and more acute attention. And in those cases, we will take somebody back to the emergency room, and either they get, a quick acute treatment in the ED and come back to us, or they get admitted back to the hospital, and we may or may not take them home once they're stable again.
Mm-hmm. And, in terms of the quadruple aim, for you as a physician, what's been the physician response to this?
Yeah, I think a lot of us who are in the home hospital program choose it because we really are invested in delivering the best care for the right patient at the right place and the right time. And so the hospital may be and often is the best place for a patient at a given moment. But there are patients that are in the hospital that actually would be equally or better served at home. And so I think that the physicians, the nurses, the EMTs are all really invested in that goal of meeting the patient where they're at, when they're ready and when they're appropriate. And I think that the traditional model has not allowed that to even be an option. Before, it was, well, if you require IV medicines, even if it's once a day, or you're just waiting for a test that you really should stay monitored for, that you need to stay in hospital because there's no other option. And I think that this is great because it gives that other option that may actually be more appropriate for the patient. And so as we've seen over the years, there are patients that are not appropriate at a given time, but as we have more capabilities, more staffing, then they do become appropriate. So I think moving forward, we're going to really see a growth in what capabilities home hospitals have.
Mm-hmm. Well, Caroline, it's been a pleasure to have you on PopHealth Week. It's really nice to see this kind of innovation going on and hearing how it's worked, and also recognizing there are things that we obviously have to continue to work on. So thanks so much for joining us on PopHealth Week.
No problem. My pleasure.
And back to you, Gregg.
And thank you, Fred. That is the last word on today's broadcast. I want to thank Carolyn Yang, MD, attending physician home health program at Brigham and Women's Hospital, for her time and insights today. Do follow Dr. Yang's work on Twitter via @BrighamHMU, @MassGenBrigham, and @BrighamWomen's, respectively, and on the web via www.homehospital.bwh.harvard.edu. And finally, if you're enjoying our work at PopHealth Week, please like the show on the podcast platform of your choice. Do share with your colleagues and consider subscribing to keep up with new episodes as they're posted. We live stream on Healthcare Now Radio weekdays, 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. And for you left coasters, 2:30 a.m., 10:30 a.m., and 6:30 Pacific. For PopHealth Week, my co-host Fred Goldstein, this is Gregg Masters saying, please stay safe, everyone. Bye now.